Hello and welcome to Pharmacomania. I am Dr. Shahenaz and we are going to discuss sulfonamide and cotrimoxazole. Sulfonamide were first antimicrobial agent effective against pyogenic bacterial infection, and Prontosol red was one of the dye included by nomenclature experimental streptococcal infection in mice and found to be highly effective. Subsequently, an infant was cured of staphylococcal septicemia, which was 100% fatal at that time. By 1937, it became clear that Prontosol was broken down in the body to release sulfonamide, which was the active antibacterial agent. In 1933, Foster reported giving Prontosol to 10-month-old infant with streptococcal septicemia and achieving dramatic cure. Prontosol and its active metabolite is sulfonamide illustrate favorable clinical result in puerperal sepsis and meningococcal infection. Now, classification of sulfonamide. It can be divided in three groups: orally absorbable, orally non-absorbable, and topical. First group is orally absorbable drug. It can also divide in three groups: shorter acting, intermediately acting, and longer acting. Shorter acting sulfonamides act for 4 to 8 hours and drug is sulfadiazine. Intermediately acting drug act for 8 to 12 hours and drug is sulfamethoxazole. Longer acting act for 7 days. Drugs are sulfadoxine and sulfamethopirazine. Orally non-absorbable drug is sulfasalazine and topical drugs are silver sulfadiazine, sulfacetamide sodium and mefenamide. Primarily, sulfonamide are bacteriostatic drug and for the effective against gram-positive as well as gram-negative organisms, and bactericidal concentration can be attained in the urine. Sensitive organisms to sulfonamides are streptococcal pyogen, H. influenza, H. decrui, Chlamydia granulomatous, Vibrio cholerae, Chlamydia species, actinomycosis, nocardia, and toxoplasmosis. When gonococci, staphylococci, meningococci, streptococci, E. coli, and Shigella are resistance organisms, and mechanism of resistance are maybe due to mutation causes overproduction of para-amino benzoic acid, altered nature of dihydroteroic acid synthetase, and loss of permeability of sulfonamide through the bacterial membrane or appearance of an alternative pathway. These are the mechanism of resistance of organism to sulfonamide. Now, mechanism of action of sulfonamide. Folic acid is very essential for the growth of bacteria as it is crucial for the nucleic acid synthesis. Many bacteria synthesize their own folic acid from para-aminobenzoic acid, and sulfonamide as structure analog to para-aminobenzoic acid enter the sequence in the place of para-aminobenzoic acid, and sulfonamide compete the enzyme dihydroteroic acid synthetase to create non-functional analog of folic acid. This is of no use of bacteria, hence growth cases and bacteriostatic action occur. Folic acid is very essential for the growth of bacteria as it is crucial for nucleic acid synthesis, and pteridine, para-aminobenzoic acid and glutamate. These three components are very important for the formation of folic acid. Many bacteria synthesize their own folic acid with the help of the para-aminobenzoic acid. But sulfonamide are structurally analog of para-aminobenzoic acid and enter in the sequence of in the place of para-aminobenzoic acid. Sulfonamide compete for the enzyme dihydroteroic acid and synthesize non-functional analog of folic acid. This is no use of bacteria, hence growth ceases and bacteriostatic action occur. As human absorb folic acid directly from the diet, and sulfonamide are selectively toxic to the bacteria only and not to the host cell. Pharmacokinetic parameters: rapidly and well absorbed orally and widely distributed in the body, crosses blood-brain barrier and placenta, accumulates in the prostatic fluid, and extent of plasma protein binding is differ. Longer acting agents are highly protein bound and metabolized by acetylation in the liver, and acetylated metabolites are inactivated but still contributed to side effect and less soluble in the acetic urine, causes precipitation of crystalluria and renal toxicity can occur. Excreted by kidney and glomerular filtration. More lipid soluble agents are highly reabsorbed and longer acting. Clinical uses: orally absorbable sulfonamide used in acute uncomplicated urinary tract infection and third choice drug in nocardiosis, xanthroid and lymphogranulomas. Orally non-absorbable sulfonamide like sulfasalazine is the drug of choice for the ulcerative colitis, and it is also used in rheumatoid arthritis. Topical sulfonamide used as a sodium sulfacetamide in ophthalmic solution and ointment in trachoma and bacterial conjunctivitis. When silver sulfadazine, it is least toxic and preferred over mefenide, and it is a slowly released silver ion additional to antimicrobial action. It is used prophylaxis in infection in the burn, and it is active against pseudomonas. Now, adverse effect of sulfonamides are crystalluria plus renal toxicity. It is dose related, and acetylated metabolites are less soluble in acidic urine, causes precipitation in the kidney and renal tubules, causes crystalluria and renal obstruction can occur. The risk can be minimized by taking plenty of fluid and alkalinization of urine. Hypersensitivity reaction arises specially as at a mucocutaneous junction, Stevens-Johnson syndrome, erythema multiforme, ulceration of the mucous membrane and malaise, eosinophilia, drug fever, exfoliative dermatitis. These all are hypersensitivity reaction of the sulfonamide. These are the sulfa reaction, Stevens-Johnson syndrome and toxic epidermal necrolysis. These both are due to sulfonamide, and both serious skin condition, but toxic epidermal necrolysis is more severe form with toxic epidermal necrolysis involve greater than 30% of body surface area detachment, and Stevens-Johnson syndrome involve less than 10% of body surface area. Hemolysis can occur in the patient with G6PD deficiency, and neutropenia, agranulocytosis and thrombocytopenia can occur. And connectors in neonate can occur especially premature infants, since their blood-brain barrier are not fully developed. So, sulfonamide displaces the bilirubin from the protein binding site, and bilirubin passes through the blood-brain barrier and deposited into the basal ganglia and subthalamic nucleus. So, connectors can occur in neonates. Other adverse effects like nausea, vomiting, epigastric pain and hepatitis can occur due to sulfonamides. Drug interactions are: sulfonamide displaces phenytoin, tolbutamide and warfarin from protein binding site and increase toxicity of drug, and it also displaces methotrexate from the binding site and decrease renal excretion and toxicity can occur. Now, cotrimoxazole introduced in 1969, and it is rational fixed dose combination of the sulfamethoxazole and trimethoprim. In both drugs are bacteriostatic when given alone, but in combination it is bactericidal. Cotrimoxazole act as a sequential block. First step, sulfamethoxazole block dihydrotoroic acid synthetase enzyme, and second block is at the trimethoprim at dihydrofolate reductase enzyme. Now trimethoprim versus sulfamethoxazole. Trimethoprim is diaminopyrimidine related anti-malarial drug. It is pyrimethamine, and mechanism of action is it inhibits bacterial dihydrofolate reductase enzyme, when sulfamethoxazole is intermediately acting para-aminobenzoic acid structurally analog, and mechanism of action is it inhibits folate synthetase enzyme. So it is the sequential block, and human folate metabolism is not interfered by this drug, and uh, single both drugs are bacteriostatic. When it is given in combination, they are bactericidal, and pharmacokinetic are almost similar to each other. uh, More rapidly metabolized, 40 to 65% plasma protein binding, partly metabolized in liver and excreted by urine. Now rationale of cotrimoxazole. Both compounds have similar half-life, that is 10 hours. Two bacteriostatic drug produces bactericidal action when combined. Combination has a wider bacterial spectrum. Combination delayed the development of bacterial resistance. The minimum inhibitory concentration of each compound can be reduced 3 to 6 times. Trimethoprim enter many tissues and has longer volume of distribution. Antibacterial spectrum of cotrimoxazole. All organisms sensitive to sulfonamides are sensitive to cotrimoxazole. Additional organisms are S. typhi, Klebsiella, P0SE are sensitive to cotrimoxazole, and resistance strains are Staph aureus, Staph pyogen, Shigella, E. coli, H. influenza, gonococci and meningococci are resistant to cotrimoxazole, and mechanism of resistance is mostly through the plasmid mediated acquisition of dihydrofolate reductase enzyme, and resistance to combination is slow to develop compared to single drug. Optimal synergy in case of most organisms exhibit at the concentration ratio of sulfamethoxazole 20 and trimethoprim 1. The minimum inhibitory concentration of each component may be reduced by 3 to 6 times. This ratio is obtained in the plasma when the two are given in dose of 5:1, because trimethoprim is more lipid soluble, enters many tissue, has larger volume of distribution than sulfamethoxazole, and at a lower plasma concentration, and its plasma protein binding is 40% of trimethoprim, and sulfamethoxazole is 65%. So pediatric dose is 20 mg trimethoprim and 100 mg sulfamethoxazole, when adult dose 160 mg trimethoprim and 800 mg sulfamethoxazole is given. Uses of cotrimoxazole. Cotrimoxazole is still in use, and its popularity has decreased in the treatment of systemic infection. Use in urinary tract infection. In acute uncomplicated infection, respond rapidly. One tablet twice daily for 3 to 10 days. In acute cystitis, single dose of 4 tablet can be given. Prostatitis. In acute prostatitis, 1 tablet twice daily for 3 weeks, and in chronic prostatitis, 1 tablet twice daily for 6 to 12 weeks. Respiratory tract infection. Upper respiratory tract infection and lower respiratory tract infection, chronic bronchitis, sinusitis, otitis media, especially infection caused by gram-positive cocci and Haemophilus species. 1 tablet double strength tablet twice a day. Bacterial diarrhea and dysentery, acute gastroenteritis, traveler diarrhea, and cholera due to E. coli, Shigella, non-typhoid Salmonella, Yersinia. One double strength tablet twice daily for 7 days. Fluoroquinolone are the drug of choice and however cotrimoxazole is valuable alternative. Pneumocystic cirrhosis. High dose of cotrimoxazole is prophylactic as well as therapeutic uses. Drug of choice for the pneumonia due to P. cirrhosis. Treatment: one double strength tablet 4 times a day for 2 to 3 weeks, and for prophylaxis one double strength tablet daily. Adverse effect necessitate discontinuation in 20% of patients. Sexual transmitted diseases like chancroid, non-specific urethritis, lymphogranuloma, and gonorrhea. Cotrimoxazole is third drug of choice, and it is given one double strength tablet twice a day for 14 days. Nocardiosis, drug of choice for pulmonary lesion, brain abscess due to nocardia. Typhoid, it is initially effective, but nowadays it is no role of the cotrimoxazole in the typhoid fever. Adverse effect of cotrimoxazole. All adverse effects seen with the sulfonamide can be seen with cotrimoxazole. Other effects are nausea, vomiting, headache, stomatitis, rashes, folate deficiency only in patients with marginal folate level, and blood dysuresis. Cotrimoxazole is contraindicated in pregnancy as trimethoprim is antifolate, and theoretically teratogenic risks are there, and given near the term methemoglobinemia and neonatal hemolysis can occur, and uremia in the renal diseases, and greater risk of bone marrow toxicity in the elderly people, and other contraindication like fever, rashes, bone marrow hyperplasia, and AIDS patient with P. cirrhosis infection. Drug interaction with cotrimoxazole like diuretic and cotrimoxazole causes higher incidence of thrombocytopenia can occur. In recent advances, ectaprime is the recent newer drug and introduced in 2008, trimethoprim analo, and the route of drug administration is intravenous, more effective and better tolerated than the trimethoprim, equally effective as linezolide and methicillin resistant streptococci infection, skin and soft tissue infection, highly effective against vancomycin resistance, stay 4 years. Phase 3 trial are being conducted to explore whether the same efficacy is retained if administered orally. Thank you for watching the video. Please like, share and subscribe the channel.